a week doesn't seem long enough to accomplish what we needed to accomplish, but Pat, we're glad you're back with us tonight simply, and we know you've been under a lot of pressure to get these numbers out, so I appreciate all your efforts and letting others do somewhat better. So the first item is the request from Florida Hospital Waterman.
David O'Connor, Florida Hospital Waterman. Appreciate the time again. I appreciate the work that you're doing. Just wanted to restate the request. Our request would remain the $4 million as indicated, based off of what we believe we will receive or the work that we'll be doing, and we'll surpass that next year. We would like to have the $3,180,590 applied towards Medicaid, their Medicaid program if possible. Let's kind of break that up a little bit, and the rest applied to LIP if that's what we are allocated. We have in the records we have about $458,895 that for this year we're willing and prepared to write a check back to the board, to the community. Thanks.
Are there any questions? The next request is from Leesburg Regional Medical Center.
I'm Phil Nolan, Leesburg Regional Medical Center. We would just let our request that we presented last time stand. Again, when we get to, I know we're not to the allocation part, but when we get to the allocation part, it's really important that we do have these letters of agreement for the $3,321,509 that we had requested for that. Again, our total funding request was $4,059,601, which is the amount that we historically met this year. And I think it actually went up a little bit after they readjusted the cost reports, but we're good with that request. Is there a question?
Yeah, I've got one question, because your request amount is less than your letters of agreement amount.
Well, the other letter of agreement, one of our other requests was to use that 542.
Add the two in this afternoon.
Okay, so I have the letters of agreement. The first letter of agreement, I guess, in the allocations of our funding would be $3,321,509. For the record, that would be for the add-on payments to the exemption and buybacks. And then there would be a $738,901 LIP funding agreement that would to be used for the LIP funding. And then the $542,601 is the credit that we previously discussed.
Yes, so the first two total $4,604,10. So $809 more.
All right, you got the attorney up here doing the numbers again. I thought that we had added that, but maybe
What you sent.
it's matching the numbers that we put on the spreadsheet last time.
But the second list that you sent me this afternoon that you said was revision was the same numbers as the first one that you sent me earlier today. So maybe you didn't send me the...
I want to get your numbers together.
Yeah.
Well, yeah, I mean, these are the...
This is what was submitted.
Well, yeah, the number went up from the, and we can get the auditor here. It's the auditor that when they recalculated the amounts from last year, it went up $795,098. That is actually, I guess, what I'm making my request for this year going forward to match what we provided in funding last year. So it's the same amount of money that we had certified and provided last year. So it would be the $3,321,509 for the buyback and exemption program, and then the $795,098 for the LIP funding, if that is what is approved in the allocations. Did I clarify that? I forgot, the auditor just got that report to us.
I think with Pat on the
We'll-
lift one that you sent over was the 738, and that's the one I provided to the board when we get the letters of agreement.
Yeah,
Now
I think,
we have to correct.
and I think that we talked with Waterman as well. I think with the letters of agreement for the lift, just so we're talking about the lift, that does not have an October 1st deadline, so we can re-put those numbers in
Okay.
and get those numbers in once those allocations are decided. The one that has to be signed tonight, admittedly, is the $3 million one with the matching.
Okay, and next we have Live Stream Behavioral Center.
Thank you again for allowing us to restate our request. First thing we're requesting is to move $127,370.65 in this year's budget, the year that we're in now, from the operation of the primary care clinic over to the hospital, and we've already provided services, indigent services, to earn that money in our hospital. We're requesting for next year, we're opening up a new clinic. We have 2 primary care clinics, one in Eustis and one in Williamsburg. And we're asking for $520,000 for that. And then we're asking for $563,000, which is pretty much the amount we earned this year providing indigent services in the hospital. Are there any questions?
Any questions?
No, but, I believe Mr. Bone's motion last week took care of the $127,000.
Any other payments that go to the hospital,
And,
we pay back and go to the LRS.
and to Leicester. So that's been taken care of.
Okay, and for the hospital, Waterman, the primary health clinic.
Good evening, my name is Anita Young, and I'm with the Hospital Waterman and representing the Community Primary Health Clinic. We'd like to restate our request from last week of $240,000 for the clinic. This is based on historical data from Q3 and Q4 that was submitted for reimbursement, which was roughly over $120,000 for those 2 quarters, so annualized would be $240,000. So our request again is $240,000 for this coming year.
Are there any further questions?
Thank you very much.
Thank you. And we have St. Luke's free medical and dental clinic. They're not here. We have the request from last week. And that was $809. Okay, and we also have with us this evening Community Health Centers, Jeff Bowman.
Hello, I'm Jeff Bowman from Community Health Centers. I wanted to thank you for your support last year of the $150,000 you provided. That allowed us to see 1,800 individuals that were within 200% of the poverty level. So your support was greatly appreciated in helping us make that impact. I'd like to request that we continue that funding at $150,000 for the coming years. We can continue to serve the mission of providing care to those uninsured in Leesburg and surrounding North Lake County communities. Thank you.
Are there any questions? And we will try to do a better job next year letting you know or reminding you of the deadlines.
Thank you.
Okay. At this time, we will have discussion for the budget and related budget items. Pat, is there anything you would like to go over?
All right, let me just explain the 3 worksheets that I did this afternoon. And then when you actually get into your budget hearing, you'll see what's going on. I redid the ones that list the clinics and the hospitals, what was budgeted this year, what was payable in the different quarters, so what was totally allowable in the over-under budget. You'll come down and look at So the acute care, the $458,895 is what Alderman's going to write us a check back for, and we're writing a check to LRMC for the $795,098. And that's all happening in this budget year you're in now. So we'll have a receivable and payable on the books. It's all transpired by Monday. So that's that sheet. Also, I did a funding proposal worksheet that tells you the funding requests, which are about $9.8 million, and then the next column there is if you just allocated on basic percentages, how it would be, and then the last column, letters of agreement requests from the two hospitals. So when we get into that discussion, we'll have that on paper. The other one I did is the up and down one, the budget scenario one. Because numbers changed since last week, and also there was some talk about not carrying over as large a fund balance for the next year, that we just have to wait till November when tax money starts coming in to write the 9/30 quarter checks to the clinic. So what you've got on that is actual through today, and it includes the checks to the clinics if everything is approved tonight. You see the $795 that will be payable to LRMC, and the negative $458 means it's money coming back into us. The next column says budget 1 mil as advertised. That's the way it was advertised in the paper based on last week. The next column over is if you still approve the 1 mil and reduce the fund balance that you want to carry forward, then that gives you a new amount for allocating in the budget. So when you get to those points, these are just worksheets so you can scribble and kind of follow all these numbers. And then when we get to that point, you can ask questions and get some clarification.
Okay. Is there any discussion? I assume all of the recipients have received your information, the budget. Okay, we've got a question. We'll open up for public hearing in a few minutes.
And the worksheets are all back there on the table.
Okay, you have not received those.
That's 3 of them. But again, the copies that gave a lot of people that came in.
Does the board have any items for discussion? Or questions?
So on the funding request, or on the ad valorem amount at the 1 mil is $8,389,700, and then where's the number that you have on the funding request down on the proposal worksheet? The $8,314,000.
Down under unallocated medical care. All in the last column.
Gotcha. Okay.
Okay, did you have a question?
I was just trying to see where the number, where the budget available number was coming from. I don't see that. I don't see it exactly the 1 mil budget there.
It's not,
Okay.
because that budget is in the newspaper. If you look at the funding proposal worksheet, you see under the $8,000,003, you see the $7,000,008.
Microphone.
The $7,000,008.67 number. Now follow that number over to the 1 mil budget.
Okay, I got you. All right. That's the revised amount then. Okay.
So you're comfortable with 50,000 on that funding balance there? Is it time to talk about that?
Yeah, the reason was that I was holding the 400 so we could have money to pay the clinics.
Right.
But some phone calls this afternoon said if we can put that 400 in the budget, go ahead and put it in the budget, and then I will start getting tax money in November. So, and the September 30th audit won't be ready till November, so I should have money to pay the clinics. And we always do the letters of agreement amount. We have to double up payments in January, so that's not really an issue.
So you're comfortable with that?
Yeah.
I did have a budget issue that I was just going to bring up for this discussion, so I guess it would be appropriate now to talk about it, would be related to the fund balance. And that is that there has been some requests from the public about an office, someone to speak to, a phone number to call, and I don't know if that's something that the board wants to consider or will consider to have an actual office, have a person in it. I don't know what the person would do 99.9% of the time during the year, other than just right before our budgeting and hearings. But it has been something that's been suggested and requested, and it would be for salary, rent, phone, and so forth. And I think 50,000 as a fund balance probably wouldn't be sufficient to cover that.
How did the rest of you feel about the office? I have heard that too. I'm not personally in favor of it, so for discussion.
I was a little concerned about the future, and we're not sure what's going to happen here a few years from now. And I'm trying to be a little prudent with the taxpayers' money and trying to establish a little more permanence there. That was my apprehension. We originally talked potentially about employing someone after Mr. Carpenter left, and tried to potentially engage his services if they were available, and they weren't at the time. But as I think our transition seemed to be going pretty smoothly, hopefully with the website we can continue to be just as transparent as possible, but I don't know if that's a prudent use of dollars.
I don't think we could have paid Mr. Carpenter to do what he
Yes, we all have a favor, there's no doubt about that.
More discussion?
Yeah, I just wonder if citizens do have questions, so where do they go?
Well, again, I'm
Website.
hoping that, and Brown said it well, that we can become more efficient on our website, more interactive. I'm not a web person, so I don't know exactly what we can do, but I think there are things we can do rather than having an office at this time particularly. But I've had people that have suggested that.
I support what you're trying to say. I just don't see it right now, especially with the future in the air. I mean, I guess we can make more of an effort to be a little more transparent if that's what people need.
I can tell you that we have not had one phone call this year about the tax board. And it's our phone number, my phone number is given out. And if people want to see anything, all the legal records are there. And we've never.
And I've been on the website. I'm sure it's got your telephone number there.
It has both our telephone numbers, our email address, and our physical location. I've had a couple of inquiries by both email and telephone, but both Pat's office and my office is on the website under Contact Us.
Not so much of a demand that it would you need to have someone
3 or
else.
4 people.
If somebody would like to make a motion, though, we can put that up again. Don't feel the need for it. We'll move forward. Pat, I have a question. Why would the property appraiser's fees jump up so much from one year to the next? The actual didn't, but then we've got it budgeted for higher amount.
Yeah, his office sends an actual budget. I printed it off. Yeah, I get an actual estimated billing from the property appraiser's office. And the North Lake Hospital District this year, $88,732 is expected to BRB. And I just take it
You
like
take it straight from
straight
there.
from this. The tax collectors is 2% of collections.
Right. And that did go up somewhat, but not a lot. So-
And, some years we get, depending on how that office runs, some years we get money returned back to us, and some years not.
Okay, are there any other questions or suggestions? Okay, do we want to open the floor back up to those that have received the worksheet that you passed out? Anybody have any questions before we move on to the public hearing?
You have to do the recitation in the middle before you address my understanding.
Okay, all right, we'll do that then. Would you like to do that? Certainly.
The name of the taxing authority is North Lake County Hospital District. The rollback rate is 1.01439 mils. Percentage of decrease over the rollback rate is 1.42%. The millage rate to be levied is 1.0 mils.
Okay.
And then discuss whether you're going to waive the reading of the tax.
Do we have a motion whether to waive the reading of the entire proposed?
Yeah.
Motion second. All in favor, say aye. Opposed? Motion.
Yeah, so, yeah.
I made the motion.
Chair second. Okay, so we will waive the reading and open the public hearing at this point. And will be for public hearing for resolution 2013-01, setting the millage. Resolution of North Lake County Hospital District providing for the adoption of the millage rate for the 2013-2014 fiscal year. So if there's anyone that would like to comment at the public hearing, now's the time to do that. Vance, I can't believe you don't have something to say.
Why? Nothing will be done.
Are there any comments? There being none, we have a motion to close this public hearing.
Motion to close the public hearing.
Is there a second?
Yes, second.
All in favor, say aye.
Aye.
Opposed? Motion carries. And now we have the hearing of the public comments for resolution number 2013-02, adoption of the budget. Resolution of the North Lake County Hospital District providing for the adoption of the proposed budget for the 2013-2014 fiscal year. Are we okay? Do we need to back up to the last public hearing? Okay, is there anyone that has a question or comment on the budget? Resolution 2013-02.
Just want to remind this board, you adopt the budget at the fund level, so all that breakdown is just for informational purposes on how we arrived at the total number, and you can still approve the budget without having specific funding in mind, because once you've approved the millage and you approve the budget, then we'll know that total amount you have available then to come up with funding agreements.
Does everybody understand? Okay, if there's no one that would like to speak to public comments, do we have a motion to close the public hearing?
Motion closed.
And a second? All in favor?
Aye.
Opposed? Motion carries. The public hearings are closed. So we need a separate vote for the motion to adopt the tentative village rate, 1 mil. Do you have a motion? Anybody?
Yeah, I'll make a motion to adopt the tentative village rate at 1 mil, and based on the presentations from last week in particular that were given, I won't repeat all of that, but I think I made a motion last week and incorporate what I stated in that motion.
Do we have a second?
Yeah, second.
All in favor of the motion, signify by saying aye.
Aye.
And opposed? Aye. Motion carries, votes 4-1, and it passes. And moving on to resolution 2013-02, motion and adoption of the budget, a separate vote as presented. Do we have a motion to approve the budget?
To approve it, and with well, I guess the option was more to see that you've got the 1 mil and then with the revised, one of those two or anything else.
Right, well, that's what that's. Okay.
I make a motion to adopt the budget with revision,
And is,
to hold back so that there will be a smaller fund balance.
with the revision. That's the motion. Do we have a second?
Yeah, I agree. Second, please.
David, are there any questions? Further comments?
Can I ask your motion to be that you're going to adopt the budget with total expense and carry forward of $9,292,100?
Okay, yeah, to adopt the budget with the total expense and carry over for the $9,292,100.
With that clarification, so okay with the second?
Yeah, so good, thank you.
Any other questions or clarifications? If not, all in favor of the motion, say aye.
Aye.
Those opposed, motion carries, the vote is unanimous. So now we have the allocation of the funding.
Okay, can I get clarification? And then we can proceed. I look at the funding proposal worksheet.
Okay.
Are you in the funding request? No, you're the last one at LNC.
Right.
Should the funding request then be the same as the overlay of $4,064,10?
Yes, when I came up here, that's what we had requested. We request that knowing, and I'm just acknowledging that there is more request than there is available funding. We know that, but we are requesting that because that was our historical amount. And when we spoke last in previous meetings and we set up this system, the idea behind it was we would look at historical amounts going forward. You know, wish we had more years to look at. We could average years and do all those things, and I think that's the future. But right now we only have 1 year. We know that that's what we did last year, and we know that we probably also, as others, could probably will find more than what we did last year. But there's no reason to ask for more than what we did last year. And I do realize that it's an increase from our previous request, but that's because the audit came in just recently, and if we had had that audit number, that's what we would have requested. I understand if we look at the original request, that makes sense to me.
So I don't know how you want to discuss and handle the funding request. The LRMC, is it buyback from the $3 million? That's the one with the highest return on it, correct?
Yeah, yes, ma'am. It's the highest return, and that would be for both hospitals.
Right. All right, that amount, if you want to write on your worksheet, is $3,321,509 for LRC. For Waterman, it's $3,180,594.
Right, and then for us, it's the, just for clarification, it's the self-funded buyback for outpatient amounts and the self-funded DRG add-on is what those two numbers compromise. And then for Waterman, there's actually 3 matching programs. It's also the self-funded DRG add-on, the self-funded exemption, and the self-funded buyback. So buyback and exemptions, that's where, as we've talked about in the past, that's where the Medicaid rates come up and our buyback. Because again, not even a full cost, just a part of our cost.
Okay, Pat, what's your suggestion? And as a vote, this is the decision of the board this time.
Well, it's hard to say because you're, now that everybody's got their feet wet, they're kind of learning how to do this, and if they're return patients, you've got the information, so you're not having to track things down and all. They're all good requests. One thing was mentioned in the new legislation that you're operating under now. Part of the encouragement was to move money into the clinics, trying to keep people out of the ER. And the other issue is in the old days, Lightstream always got 5% of the proceeds. So, when I calculated today, I think that one still falls in okay. 5% is $415,000, so they're getting their request takes care of that. So I just don't know, it's going to be your philosophy and how you want to. Okay, you see what I did in that one column is the percentage of requests. I just took the request to the total and said, there it is. Another way you could approach this is do the hospitals, those large amounts, and then make a pool of the clinics and let them, as they have allowable, we pay until we run out of funds.
How would that work? Is it paid differently than that? I mean, if we allocate like that, are you nervous about doing that properly?
Well, it'll work if it all comes in as rapidly over the year. If some clinic pushed in a lot up front, but if we did it that way where there's this pool of money, and that's what, if you look at the LOA request, the very last column there, if you did the total LOA, the LOA is letters of agreement, those are the ones with opt-in mistakes. Then you would have a pool of $773,000 to go to everything else. But, if everybody met what they did last year, then that's not enough funding for the clinics. So, I don't know if you want to do the, like I said, the buybacks give the biggest bang on the buck for the hospitals. And then the lift doesn't get as big of a return. So we may have to do some funding tonight, see how it goes in next June, see where our pot of money is. And go from there. It's just, you've got to $1.5 million requested more than you have money.
Madam Chairman, can I comment? Are you at the point for comment?
Dan Schuppen. I'd like to suggest, one is that I believe that the earlier allocation, and maybe someone can help me with this, but when it was first set up to allocate these funds, wasn't it based upon the population in the two districts? And that was a base that was used for that, and now you're changing that whole game plan. And as a resident of one of the districts, either one, I would think it would be equalized based upon the population between the two hospitals.
The old legislation made me allocate it northeast, northwest. The new legislation totally did away with that. We don't have any delineation in the new legislation anymore.
But how did this initial allocation that you had for this current year take place? That Waterman was significantly higher than Leesburg. Is that based upon population?
Request.
Okay. What I'd like to, if I could just finish my point, is since the new legislation was emphasizing trying to shift the cost to clinics where they touch a lot more people for the average, which is significantly less than hospitals, I would suggest as a taxpayer advocate, instead you take the money off the top for the full requests from the individual clinics, and then you take the remainder and you allocate it among the two hospitals based upon population, because I think that we have a situation here where we have two hospitals. One was much more aggressive in building up the numbers than the other, and then using that as a base when I don't think that's appropriate. I mean, I can tell you flat out, having worked in manufacturing companies, we've never done that for allocating costs between, say, plants or something. We base it upon something that's got a sound basis to it. And because both of them have requested more than what they've got, and so you ought to have a formula. But I really recommend you take the clinics first, because I think they're more efficient, they generate more coverage, and then what's remaining, which is the reverse of what she's talking about. So that's for your consideration. Thank you.
Okay, thank you. Thanks.
Yeah, where I want to start. I think for historical purposes, and I know Kent's out there, so he can go to speak to this. I think there's a couple things. It was per capita. So it was really based on the amount of taxes that was collected in each district, and that's how it was divided. So it was property values were factored in there. So it wasn't just pure population. But Pat is correct. That has gone away, and there is no dividing line. And in fact, the only reason last year's allocations were that way was because we, Leesburg Regional, felt that not having any, again, historical value, historical figures to go on, and not having done this, we felt comfortable that allocation we would be able to meet that number in charity care, and we did, and then some. And as far as being able to ratchet up costs, it's really not the fact that we ratcheted up costs. It's again, and the auditor can come up here and talk about it, but there is a formula. It's very well documented. You don't get credit for the care unless you document and provide the care. So that number that we provided in care, we truly provided to residents of the district. I understand what Nancy's saying about the clinics. I do think there was some idea about the clinics. I think the bill was poorly written to help the clinics because they're only getting the cost, but the clinics will take that. But that's something I think the district board should keep in mind, is at least two of the clinics involved in this tax district decision are clinics that will be funded and supported by the hospitals. And I don't want to take away from the clinics, but I think in my mind, and even as a taxpayer, a better use of that money is going to be to put it, although it's smaller than the exemption, is to put it in that LIP program to get that money back into the community. And we're going to give that money, whatever the clinic's shortfall is, we've been paying the shortfall of the clinic. So your and I don't want to speak for Waterman, I imagine if their clinic got a shortfall, they're gonna make up for their clinic. So, to not at least get some of that funding match, I just think that is important. I guess I would throw out, to me, you know, and I think it was discussed last year, and I don't want to die on the sword for it, and I don't want to hurt other organizations for it, but I think the fairest thing was what we talked about, to be as close to historic as we did. I mean, that's what we all, when we put together the agreed procedures, and I don't have a copy of them, I apologize, I don't have a copy of them, because I don't really recall what was finalized or what wasn't, so it may be in the records, but I'm pretty sure if we look back in the minutes, it was said that we would look at the historic numbers and we would base allocations going forward by historic numbers. Now, I don't even know if you went historic, I'm again not good at math, but I think you're still short of money. If you went solely on this allowable sheet here, on the allowable cost, which would be the historic numbers that everybody did, I think you're still a little short. So I could see, you know, I think the hospitals would gladly, you know, split the haircut on that historical short cost. But if you went solely from historical, the chances are some of these clinics, because they didn't meet their budgets last year, may not meet them again if you went to the other side. So if you do that, you'll leave money outside of the matching programs. I understand that the clinics, I can't disagree with that, but until you start paying the clinics more than their cost, you're not going to help them tremendously. They've got to get more payment than their cost. They don't have the other services, and they don't have Medicaid to help match, so they can't leverage the funding, unfortunately. I mean, that's an opportunity in the legislature. There's a way for them to start matching the funding. It would make more sense to put it in there. So I guess what I was long and short, I'm sorry for being long-winded, but I think if you went something closer to the historical, you'd be a little bit short, but not that much short, and you could then haircut, if anybody, the hospitals on their historical numbers in an equitable manner. I think that's probably the most equitable. Does that make sense? Did that make sense, or was I too rambling?
No, that's helpful. Are there any questions?
I think we have to take into consideration, talking about the clinics, you know, didn't use all their money last year. Well, they had a learning curve there. And a lot of them have said, as they presented their budget, that this year they didn't have that learning curve, and therefore that money will be put to use.
I think it's been a learning curve for everybody for the whole year, and so it's all brand new. I think we're going to continue to have a shortfall.
You might find it helpful to go ahead and get the Moore Stevens report, because on the last page is your statistics for the year.
All right.
And I've been kind of adding up as we've been discussing. You know, you've got the last column there, the average reimbursement per encounter. And then if you add up the encounters, Waterman had 4,158 encounters. Central Florida, 2,080. Livestream, 1,884. So I don't know if, and I haven't finished adding up the clinics, I'll do that. Yard, 1506. Far Hospital Warman, 1611. Community Health Center, 1945. I don't know if you want to look at, people served out in that around here.
I think we're going to continue to have a shortfall with the medical situation as it is now. The country will have that. Because if the hospitals got the historic share, as Phil mentioned, and that money is being leveraged. Clinics aren't leveraging the dollars from the state, so that's money that could be returned to the community that we would not be getting. But as you mentioned, that would be a point for the legislature to take up. So, you folks have all been on the board a lot longer than I have. Also.
Talk about the, what, $290,000 shortfall financial request and what they have. Sorry, you talked about what, $289,000 shortfall with the clinic's request and allowable rate. Is there any way we could reserve that amount in some fashion? I mean, it's easy for us to throw in the pool, let the hospitals get it, take the difference and disperse that to the clinics, but I'm trying to think of a hybrid route somehow where we can ensure that the clinics can get this money and somehow reserve that from the two hospitals in some fashion. The negative, of course, of that is the matching funds, and that's really the quest. How much of a bite do we want to take on that? How much do we want to sacrifice giving it to the clinics and not having that matched? And that's a difficult decision. I personally do think the clinics are very frugal with the money, and it certainly should be taken into account to maybe sacrifice potentially some of the matching funds to be sure we fully fund the clinics. Now, I don't know whether we can take that and, like I said, reserve that $280,000 in some fashion and word it such that they can reserve that for their use. If they don't use it within a certain amount of time, it can flow back to the hospital. But I don't know whether that's feasible or not. That's the line of thinking, my line of thinking a little bit. I mean, I'd like to fully fund these clinics just as much as we can. I think you've got the heart and soul there. The hospitals do a wonderful job too, and they have the staff to do it. And we want to help everybody, but $100,000 budget, that's the guy who runs into the problem. If you can't make a payment or quick. So I don't know if my thought process is right there, but.
Okay. Further discussion?
I just want to point out that live stream, excuse me, for every $3 you give us, no, for every $1 you give us, the state gives us $3. So we're getting a match also. We're leveraging the money to bring in state money. So I just wanted to point that out. That's never been taken into consideration here before, but if you're taking that into consideration for the other two hospitals, I think you should take it into consideration for us.
I think there's a lot of ways to slice this, but the consideration being given to the clinics to say, well, we want to make sure we have enough, that there are as much funds as possible to meet their needs, and at the same time look at the hospitals where they get the matching funds, and that means there's some reasons to maximize that to the extent we can. There's kind of a balance between the two, and to me it almost seems like the best way to do that is just to do an allocation of percentages, based on the requests that are made and the funds that are available. Looking at the clinics and what their allowable was last year compared to their budget amount, that may not be the right numbers to look to. I mean, they were 66% of what was requested, 50% of what was requested, 79% of what was requested, 33% of what was requested. So there's compared to those numbers, there's a pretty good cushion. Now, a couple of the requests are less for this year from Community Medical Center and the primary health clinic there. But and just looking at it, I mean, there's all kinds of ways you could try to approach it. And I just feel like if we did the percentages, that would provide not the full amount that the hospitals are requesting, but it would provide a significant amount to them and still provide money to the clinic. And as it happened this year, the clinics weren't able to support the full amount that they had requested, and that left funds available to be reimbursed back to Lightstream in the hospital. And I think, as it turned out, I think that works pretty well as it happened. And that's my thoughts on it. I mean, I don't.
You mean like across the board, same percentage for everybody, 85% of what they request?
Just as she's as Pat's thrown it up here, and that's my thought on it.
And I see where you're coming from on that. I think, like, just to better clarify what I was trying to get to, and we talked a little bit more, that reserve idea is probably a pretty good idea. I mean, we would lose a little bit of the matching, but if you did set aside, which is similar to what you're doing, but I think if you did it historically and then took off the top of the hospitals enough to get the clinics back up, then you would have a better way of looking at it. And that way we would ensure that we first get that buyback and exemption match, but then you could take $150,000 from each hospital off the top, or 200, 150, and that leave that in the pool for the clinic, and then if they didn't use it, reserve it back to the hospitals. And you can include Lightstream in the hospital mix if they want, or maybe a smaller percentage, but something like that.
If you fund the hospital, the buyback, the $3,180,000, and do all the funding requests for the clinics, that would be $8,185,000. You could kind of do that then with the idea that anything left over would go in proportion to the two hospitals.
So that's the $3,321,000, $3,180,000.
Because that you want to maintain that because that's the biggest payment back. The next one, the lift, doesn't. What's the percentage on the lift? About 800. Okay, so what's the? And I want to buy that. 17 facilities.
It varies on patients. It's double.
But then there again, when next June, we see, okay, we have this pool of money left. The two hospitals would have provided more service than they would pay for it, then.
It's possible that Clinton could have provided might provide more service as well. So.
That would be reserved for them of what, about 120,000, something like that? Is that? In ballpark?
I got a question. By doing so, how many times last year? We're just going to go with that. Are we looking at a year and a half? Are we going to try to create a new historical off of this? Or?
That's a good question. I think this first year, since things are so new and chaotic, I don't know whether we, at this meeting, or at this time, want to try and create standards for the future. There's still a lot to be learned here. I'm not sure if we want to do that at this time. But how much is that shortfall amount between, you said 185 and 8314? You've got what, about 120,000, right? 130.
Yeah.
Okay, and the clinic shortfall is roughly $280,000 that they're short of, and of that probably Lightstream's taking 50% of that roughly. I'm really broad on my numbers here. I hate to be so vague with them. I'd like to-
The numbers I'm adding up are the 150 to 200, the funding request.
Right.
Plus the buybacks.
Plus the buybacks, okay. Okay.
Gives you the 8,180,085.
I see, okay.
You know, because I think you also have to look at you also need to look, you know, that your schedule from Moore Stevens, and just the cost per hour. See where.
That's that question, as you're bringing that up. I think, you know, and Van had asked me this at the last meeting too, so we have done a little looking into that. A lot of our submissions are the inpatient care, not outpatient. The reason Waterman's admissions are up is because they're submitting more outpatients, which I don't know if that's easier to document or harder to document, I really don't know, but that's the difference, and that's why the difference. You know, no matter how much we fund the clinics, and again, it's hard to stand up here because I think I do believe in the clinics. We support a clinic. We think they're a good option and they're important. You will always, until there is people who are willing to take accountability for their care, which is even the ones coming to the clinic, you can treat them and treat them, but are they really doing the follow-up? Are they really doing the things they need? They're going to have acute services that they're going to need. They're going to have a heart attack. You can't do that in the clinic. They're going to break their leg. You can't do that in the clinic. I mean, those kind of things are going to happen. They're going to need surgery. They're going to need something that they need, and that's going to get done in these hospitals. And I do believe in the clinics, but you can't forget that when the serious thing happens, when the thing that's going to keep you alive happens, the preventative care is important, but it's going to be in these hospitals. And again, the massive funding, you know, that's the reason those numbers are different, because a lot of our submissions are inpatient care. They still qualify. They're still sick. I mean, we don't admit patients just to admit them. I mean, they come in through the emergency room, and they're in dire straits. They come into that emergency room, and we by law screen them for emergency medical conditions and treat them. So that kind of explains the difference. I did lawyer math here, but if you did historical, if you just went straight down to historical, you'd be about, correct me, Pat, about $400,683 short. You could take that $468,000 out of the hospitals. Maybe you do it by some kind of percentage, or maybe you do it splitting it, and put it back in the pot to make clinics so that their historical is whole, so that you're not over allocating funding. And then, then you just go for next year. I think the thing, what I would predict will happen this coming year, I know we had a surplus. I think you might have a surplus in some fashion or another, maybe, but you will have plenty of other places to put it, and you will have multiple people other than Livestream and Leesburg probably that will over-exceed their care. Probably everybody on here, no matter what you allocate, there'll probably be 3 or 4 people that are going to go over what the care is, because again, we know there's no Medicaid expansion. We know that what we predict, and we're pretty sure when these exchange comes in and people get dropped from their employers, they're not going to be able to afford, even with the government subsidy, they're not going to. Why would I pick up health insurance as a 25-year-old who's part-time employed, don't have insurance? I'm probably not going to, and they should, but they're not. And those are going to be the people we see. The other thing I didn't mention about the clinics is, they probably are having a hard time documenting, so these numbers do get harder for them to meet because of that. They also will see patients from other places too, because they're in these referral networks, and they get patients who aren't really always in the district. I mean, we get those too, but I think they see a lot more of those than probably we do even. So that might explain some of it. But that's what I saw. But I wanted to mainly explain those number of differences.
Just remember, because it's historical, the new Livestream primary care clinic had no historical this year.
if the hospitals get the full amount of their request, and that's only leaving about, not quite 300,000, is that right? For, including live streaming. Am I correct in the, if we're looking at, an amount available of 8,314,000? So if the hospital's got the full amounts that they're requesting, we're gonna have less than 300,000 available for everyone else, is that right? No?
No, that last, column on your worksheet where it says LO, that's what the two hospitals are requesting in their letters of agreement.
Okay.
4 and 4. So we have 773,000.
Right, I'm sorry, I was looking at the funding request column there, not the
Yeah.
the LOA column.
And, you know, you've got, I mean, just live stream, there's $1 million there, so I just don't know how you're gonna figure that out.
Okay?
Fran Crunk, I just wanted to clarify on our LOA request. We did submit the LOA for the Medicaid program to fund it in full, and we did submit or drafted a letter of agreement for the LIP program at a reduced amount, only because we noted from our last meeting that the total request exceeded the available funds for next year. It was our intent to always put into the LIP fund anything above and beyond that we were allocated that was above the Medicaid program. So our request is still remaining at the $4 million.
I mean, I just see it as the, if we look at the way Pat drew this up with the percentage of requested, the 85%, the hospitals would be getting less than what they both documented as their allowable care for this past year. We're allowing more than what the clinics were, what they had documented. So that does provide a pool of funds to provide them with additional funding if they're able to demonstrate that during the audits. To me, it just in balancing make sure we have some funds available for the clinics that exceed what they were able to show was allowable. The only way to do that is to reduce the percentage to the hospitals that's going to be less than what they were able to, than what they demonstrated was needed for this year. That just goes to show how great the need is in the county for this care. But I just see that as the fair way to do it and the simplest way. And there are other ways to do it, but I just see that as the fairest ways to do that. And I would look at doing the proposal or grant the request or the amount as listed in the percentage of request to total available at the 85. I guess that's 85% for everybody. Is that?
Mm-hmm.
No, I actually took, like, if you took 150,000 divided by, these are little numbers off now because the LRC number changed, but I took 150,000 divided by the 9,000,008 times the 8 million that was available, and that's what came out. And then I took the 200,000 divided by the total, the 9,800 was there, times the 8,000,003 we had available. And I did that for each request. Those numbers will change a little bit now because the funding request went up about $800, so they're not going to change much.
Okay. Is there anyone else in the audience? Ken, would you like to add any words of wisdom? And Mr. Halligan, did you have anything you would like to add? All right, do we have, we've had a lot of discussion, do we have a motion? And we put it up or down and have all the motions. It's tough when you don't have that money.
So, the two things we're going to run is to pay buybacks, total like 6.5 million. And then look at.
Use the microphone, please.
Oh, sorry. Can you hear me? Okay. If we pay the two buyback programs, okay, then the next position you look at the clinic. None of the clinics went over 80%. Okay, right? Off the allocation from last year. So if we give them 100%, in some cases they were only at 50%. And I know they may get more, but couldn't we set a benchmark of 80% of that? I mean, you still put funds away. That's a discussion we can have. That makes sense.
Another comment?
For the record, just a couple quick questions or comments. When we look at the historical component, I know in the first couple of quarters we were learning our process, and the last several quarters are much more reflective of the future of how we're doing. I wasn't here at the time, but what I'm being told is that in some regards, even in the first quarter, we had not yet even put together the rules to abide by until the second quarter, and that came into fruition. Second comment I've made that relates to the clinics, I agree clinics are extremely important, and we need to be able to use them appropriately, but maybe a philosophical question for the board relates to if next year 5 more clinics come on board and say, we want X amount, in the following year, multiple more clinics come in. What maybe the philosophy of the board saying, do we say yes to every single clinic that comes on board? Do we agree to everything that comes on board? Or is there a thought process on how to work through that from every request that may come up? I know earlier there was comments on at the end of the day, what's your stopgap if you're really sick? And the hospitals do take up front of that. We are open 24/7. At Waterman, we did have over $3 million of claims that we were not able to get the proper documentation. We are open 24/7, like Leesburg, and at the end of the day, on a weekend, a holiday, if you're sick and you're coming in, you're going to bypass everything and you're going to go to the hospitals for the care, of which we will provide to the best of our ability. So just some points to consider.
Those are good points, and that's true. The clinics are generally not open after 9 o'clock at night, and that's when a lot of your emergency care.
It's important. The clinics are very important. We can provide care at a lower cost, but maybe a philosophical question that indicates if you have 5 more clinics come tomorrow and say, hey, I need funding, what's the process of saying, okay, we'll support every clinic out there, or not? Just a thought.
So what was your suggestion? Is it 80%?
Well, I was just
That was the point.
It's just the point of looking at the numbers. I mean, we're talking about giving them the full allocation. None of them got that close to it. So could we start lower, and then if they did provide more, then you can look at that later. But will they? I don't know.
Budget amendment mid-year. Do we have any sort of
I'd love to verify everything they're asking for. We gave the hospitals everything they want. There would only be $254,871 left, if I'm correct, looking at the funding, at their funding request, and what the budget's going to allow. And that's not going to be enough for everybody else. And so there's no way we can come close to just to giving the hospitals what they want. And at the same time, I think there is some purpose behind behind the new legislation is to move some of these services over to the clinics. If I see that correctly, and so yes, the clinics need to be funded, and the funds need to be there. So there has to be enough money to provide for them. And you know, I'm just ready to I'll make a motion to just approve for the request to be granted, or not the request to be granted, but for the allocations to be made of and this may not be the correct number, but the $8,314,472, that to be allocated to the clinics and to the hospitals in live stream, according to the amounts that are listed in the next to the last column on your funding proposal worksheet. It says percentage of request to total available. To do it at those amounts, and if this needs to be part of the motion to provide that the matching programs, we need to put that in there too, or that'd be a separate, okay. And they be allocated that way, and I think last year the way we did, the funds were held until the clinics and the hospitals, or until the clinics demonstrated the allowable care, and so those monies be held until it's determined that the care that they're requesting to be reimbursed for is allowable. And to the extent that there are funds left over from those funds at the end of the budget year next year, that we then look at who exceeded the amounts that we allowed for them, and that they be allocated at that time accordingly.
Okay, do we have a second?
I'll second that.
Everybody understand the motion? And more importantly, Pat, do you understand the motion?
We have a recording. I got half of it typed up, and I have down on the recording exactly where it is in the recording.
You're okay. Before we go, Phil, did you have one more?
I'm guessing we're going into discussion on that motion now, and I understand Bob's thought process and request, but I think also in line with Dave's thought process is, we understand. I think the hospitals, and I speak for I think Waterman too, to kind of over there talking a little bit. But I think we understand that we are going to get less than what we provided last year, and that's okay. But I think I think it would be better philosophically to look at what we requested and take the haircut based on that historic number in a fair way instead of a percentage of costs. Because if you look at everybody again, if you look at everybody's historic number and you say, okay, let's base it on historic number, and then take money from their actual request, I think that would be a fairer way to look at it than just a straight percentage, because then there is, it almost seems like we're not really going back to how we historically started this. I mean, we agree to that haircut. I mean, I think we would, but I'd rather you take the haircut off the top of our request, which was based on our historic number, rather than a straight percentage, and try to fund them closer to their actual historic numbers instead of the straight percentage. That's, again, I guess part of me is saying take some money from us, but do it in a different from a different source, a different way of looking at it.
And Pat, do you have? It is a little different. It's different what you're talking about, but it'd be hard for you to figure that.
So are you saying to use the allowable from last year? Is that what you're saying?
Well, not necessarily mean you have to use it exactly, but I think that's your starting base. I think that's the number you should be looking at, because in all the discussions in the past, I mean, you can give some credit if you want to give some credit to the assumptions that they're going to do more. I understand that. you know, I don't know if the clinics,
But Bill, Waterman would fall right into that same category with them. They, what they show as their allowable from last year is less than what their
I agree, but I think that was the discussion at the table when this funding was set up, and it will change over time. I mean, this is 1 year. Next year, I'm sure it will be different, and we could be looking at we could be looking at the shortfall. I understand that, but I think the historical calculations, and then you'll be able to average them as your years go on. You'll be able to have better data, but you don't have it now. The other way of doing it is just kind of saying, well, we think they're going to do more, we think they're going to do more, but let's just allocate the cost percentage-wise. Again, knowing that we have a matching ability, and again, it costs more to take care of somebody in the hospital than it does in the clinic. So when you do the percentages, it's not really apples to apples. I think you start historically. If you want to say, okay, we think everyone's going to do a 10% more than what they did last year, then add 10% and see where you need to haircut from us to get there. But just to break it based on the total funding request, the total funding request is a number that everybody just kind of came up with, and really, we're the only ones that used our historical number when we came up with the funding request. I mean, everybody else is close or is actually asking for more. They're all asking for more than they did in care. And I don't want to not give them some more money. We're fine with that, but not just slice us based on a percentage because they ask for more. Because if they ask for more, then that percentage changes. So that I just hope we consider the historic nature and the fact that we didn't ask for more than what we approved. Everybody else on this, in fact, and Howard, I apologize for this, but Whitestream is asking for funding. You're allocating funding to a clinic that doesn't exist. $500,000 and you're taking it. I mean, I'm not purposely taking it from the hospital, and I hope you get the clinic open, and I hope you can give them some money towards it. But it doesn't exist right now. So
that's not true.
Well, but
we asked for two clinics, and one of which is open, downtown Leesburg. The other one is not open, but will be open in probably less than a month.
I'll retract that, but they asked for $500,000 more than they showed last year, and they moved money from a clinic to get to that 500, the first 500. So I don't want to take more money away, but I'm just trying to find a fair way to allocate the funding. Give us a haircut, but remember, we didn't ask for a higher percentage of funding than we showed, and you're basically, if you do the percentage request, you're factoring in their higher request. That factors into that percentage. I'm not a math person, so I can't say how it happens, but I know logically it does change their allocations. If you were to do the percentages based on available funding and then divide it out with that way versus the part using the request as part of your multiplier, I think the numbers would be different.
But Bill, I think you'll understand this too, is that or Bill, I'm sorry, Bill, you'll understand this, part of the reason we're doing the $1 million is based on the presentations that were given, that they're from the clinics as well as from the accountant, that from the auditor, that the amounts are going to go up, that the trends were that they were going to go up to justify the $1 million because the clinics were going to need additional funds beyond what they presented as allowable this year.
Right, but your historical allowable is more than $1 million this year too. So the need's more than $1 million, just even looking at historical. And I do agree, factor in some increase, but factor it in across the board, because we're not getting any factor for increase. What our request was getting factor, so you could factor in the increase across the board and as a percentage of what they did last year. Use last year's figures to monkey with the numbers to make them work, but I think that has to be the base, and I think that's what's been talked about. And again, the legislation also talks about using that matching, leveraging that fund. It's in legislation itself. So I mean,
and that's why my motion, if I can speak to my motion, that's why my motion is to try to balance things, to balance the need for the clinics, assessing that it's going to, what we're anticipating, and for Florida Waterman Hospital, that what we're anticipating is greater than what they showed as allowable last year, at the same time providing, although LRMC is going to receive less than what they showed as they're allowable, allowing the LRMC to be able to obtain as much matching funds as possible, while trying to balance that there's going to be some funds available for the clinic and for the new hospital there at Livestream. And if, other than balance, I may be wrong in my thoughts, but trying to balance everything, that's the only way that I see that it can be done is to say we're going to have to allow more than what the clinics demonstrated as allowable, and it's still going to be less than what they're requesting. LRMC, as things turned out last year, you documented very well what your allowable costs, and were able to get that, and as a result of others not being able to demonstrate their allowable, funds are being transferred from those other hospitals over to LRMC. So it worked out. You did not get the benefit of the matching on it, but the funds were shifted as according to, I think, in the spirit of what our legislation is, and that's what that's what my motion is to try to stay within the spirit of that, to the benefit as much as we can with LRMC, but also considering that there's a desire expressed in that legislation to help the clinics out.
And I agree completely, again, I agree with the haircut, but I think what I'm feeling like is that because we asked for what we showed, we're being penalized by using that formula that Pat put out. And so had we asked for $5 million, which we probably were closer to maybe if we documented perfectly, and we probably may be able to get to $5 million next year, had we not gone off our historical numbers, but gone on to wishes and hopes that we would show more than $5 million, these numbers would be different. These percentages would have come out different. So by doing the percentage across the board, we are being penalized for sticking to our historical request versus a higher request. Everybody else asked for a higher request. We asked for a historical request, and so your method penalizes. I don't mind being penalized. I know we're going to lose some money. I understand that.
Let me say this too then, that Central Florida Health Alliance, LRMC, last year was budgeted $3,307,300. What my proposal is to give that they would be allowed $3,432,526, more than what was budgeted last year.
Everybody's, yeah, but that's, again...
Everybody else is going to be, I think, be given less than what they were budgeted last year, except for the new Livestream Behavioral Center.
Well, and that, again, all I can say is that we talked about historical costs, and I was like, I'll wrap it up. I think if we had asked for more, we would have gotten more, but it would have been realistic.
Bill, you're getting more than, under my motion, you're getting more than you were budgeted last year. Nobody else is, unless I'm mistaken here. So.
Thanks.
Dan Shepard, it pains me to say this, but I kind of agree with the facts as stated by Mr. Braun. Being an attorney involved. And with all due respect to Livestream, I'm not going to say where you ought to spend this money, but just make sure you do understand that Livestream has come in and added another $500,000 above what they had received from you. So they'd be the absolute winners if you approve it this way. I still am in favor of the clinics getting more money, but I do want you to point it out because, after the fact, if some people come along and document that or something, you want to be sure that you do know that that's what you're doing. Thank you.
Okay, thank you. Ken?
Just to be real quick, I'm Ken Carpenter. I just wanted to float out the idea of possibly running the hospital-supported clinics, running the money that's allocated to them through the hospitals, so they can get, that would be added to their LIP program for the match, and then they could fund those clinics from the hospitals. I don't know if that's legally possible, but at least you're getting about $169,000 extra to LRMC and $203,000 extra to the hospital for them to get that 8.5% match from the LIP. And then they would be responsible for funding the clinics, they would still have the same documentation requirements, but, you know, it would at least throw another $200,000 each way.
I didn't think that was allowable
I
either,
just said for
but
what?
that has to be, doesn't that have to be used for Medicaid?
Yeah, well, we wouldn't be able to write an agreement that says that we would do that, but the reality is, like I said earlier, you're not covering their budget with this amount. We cover their budget, and we cover it. In fact, this year they ended up 12,000 short of what their budget, what we already were giving them, which was close to 300-something thousand. They were already short, and we cut the check to keep them balanced. So we, and I'm sure Waterman's very similar. We fund that primary care clinic. It does. When you weren't funding it, we were funding it. I mean, the only thing I think that would be a little difficult to determine would be, you would allocate it, but they would still probably under legislation have a right to bill for the patients that they do see until your money was gone. I mean, because there is a separate patient encounter that is happening over there that, you know, we certainly would be able to make up for that money with our patient encounters, but there is separate patient encounters, and I don't, you know, they you know, should probably be able to submit for those. But that, we would not, you're right, we would not be able to say in writing or otherwise that yes, we would take that money and use it for that. That's not what we would do. We already have agreements in place with the clinics. We're affiliated with them. In Waterman's case, it's actually under their umbrella. With us, we have an affiliation agreement. Basically, you know, we fund them. So.
Okay. And
Just a quick comment on that. If it goes into the hospital, you know, it would probably add about $20,000 and every bit helps. But again, I still go back to the philosophical question that if 5 more clinics come here, then what would we do at that case? Would we turn around and say, hey, we don't have the clinics anymore, let's come to the hospital, let's go ahead and fund 5 more, let's take it away from the hospitals to do it. So just as we continue going through the process, to think to that.
okay, we have a motion on the table. Any modification to the motion?
Like I said, I got some more thoughts. I don't know.
I'm not sure where we're at here, what Mr. Carpenter's suggestion was. Is that, that's over my head. I don't, you know, these things, when I start shuffling all around the hole, I think it's a great idea, but I don't know.
If I could clarify Mr. Carpenter's suggestion, I get a 401k match from my employer, and for every dollar that I contribute to my 401k plan, they drop in 50 cents. There's no better investment that I could possibly do, and there's nothing I can do with my money that's better than putting it into the 401k, so I max that out. And so what Mr. Carpenter's suggestion is, in the hospitals, I believe, from Phil's reaction, that they're in agreement, is fill up my match. Because I can use those matched dollars. If you put $1 into my match program, it becomes $2. And with that extra dollar, I can fund my clinic. It's worth more to me in the match than it is in the clinic. And so this is from a, that's what I have to say that clarifies that suggestion is that if either of the hospitals would object to that, I don't know, but generally if I was a hospital, I would say, yes, give me match dollars and I'll make sure that the clinic ends up getting funded and those services get provided.
The only thing I would say about that's fine for the 2 clinics that are associated with the hospital. What about the other clinics?
The other clinics get funded. This is what I understood. Mr. Carpenter's suggestion was that take the dollars out of those 2 clinics that are funded by the hospital, give it to the hospital where it goes to Tallahassee and comes back double. The hospitals make out in that process, and their clinics will continue to provide services. It draws down more money from Tallahassee into this community and supports the hospitals, which
as you've heard, are there for you when you need it.
And those dollars would go to the clinics, the extra dollars would go to the clinics from the state.
That would be up to the hospitals. It all goes into a pot of money at the hospital, and how they spend it is up to them. But I think, I doubt that they're going to defund their clinics. But that's a question for them. Okay. I have another thought. Oh, sorry. Mr. Chairman.
If we did do that, we could then allow those funds to fully fund the two community funding requests, and then the balance thereafter could go in the hospital, theoretically. To me, it certainly makes sense if we could do that. I wasn't under the impression we could do that, so I don't know the accounting and all of that, but it seems logical. Certainly we need to do that, but I think we need to do it on the stipulation that if we do such, that dispatching funds enable their particular clinics to get the maximum amount of funding that they request, and then the balance thereafter can go with it as they choose. But I don't think anybody on here, anybody on this board disagrees if we get money to do it without any repercussions to get more state funding. We certainly want to do that.
We can't stipulate it because of the LIP funding program would allow us to do that. But again, what I'm saying is that we are funding. I mean, if this tax district went away tomorrow, well, I shouldn't say that because that would be one of the things we'd have to consider. But if let me backtrack here. All right. I promise that we would do everything we could to keep the clinics together. But regardless if you move this money, let me talk about this money. Regardless if you move this money, we're going to fund the clinics. We're going to fund the clinics. Regardless. I mean, what I've been saying, we're going to fund those clinics whether you move it or not. But again, any money we put in the LIP, like you said, is good.
Would this be a decision that the board has to make, or is that something the hospitals and clinics can do?
You're simply just allocating money to.
We're just allocating the money.
Just for the point of discussion, let me just, y'all want to just write down to the left of the worksheet, just another, because there's been a mix of talking about historical and buyback. If it went down this way, 100,000, 160, 180, 50, 250, 563, then what is left is proportional to the two hospitals based on their request. It would be $3,479,462, $3,532,010, and that gives you $8,314,000.
You get those just.
No. That means the first one, 100, 160, 180, 50, 250, 563, 3,479,462, 3,532,10. Those numbers total $8,314,472. And that's a mix. So you've got historical on the little bump on the clinics. Live stream is, you're kind of funding the one clinic that is open and let them get a history rather than going in with a whole $500,000. Giving them their historical on the hospital and then allocating based on request on the hospital. Okay?
I have one more thought, Mr. Chairman. This is contrary to the motion I've made, but this is another way to slice it. If we took the amounts that the clinics documented, and I'm going to pick an arbitrary number, and let's say 20%, and let's add 20% onto what their allowable amounts were for this past year. I don't have the total number, you have to add it all up, but if we did that, the amounts for the clinics would actually be less than the percentage request in my motion that I've made. For example, Community Health Center, instead of it being $126,830, it would be $118,598, so forth. And we just went we added 20%. I'm going to take the new live stream clinic out of the picture for a second here, okay? With the 520. We get down to live stream behavioral center and we add 20% on to that. That's going to add another $112,583 onto their side, which would actually increase the amount here. But we've taken out the new clinic. Florida Waterman Hospital, if we added 20% onto there, they actually are going to exceed their funding request of $4 million. So it would be greater than that amount. And then LRMC, I'm not going to add the 20% on there to what their document was in this situation, because what I'm looking at here is actually more than what I just made my motion to them. But essentially, I don't know the math, don't know the numbers on that, and it's not addressing fully the new clinic at Livestream, so I don't know if this would work. But if you see what my thought is on this, is to pick a number and say, let's increase what the clinics were able to show as their allowable amount by a certain percentage, 20% is what my thought was, and then that would also provide, adding that additional amount to the Livestream Behavioral Center of $112,000. We've got the Florida Waterman Hospital then, and the Central Florida Health Alliance that is going to provide some additional funds, and just how would you allocate those in the budget request? That's just another thought. Like I said, there's just so many ways to slice this thing without. We're
I don't know though that it's going to work, because if you look at the allowable total, $8,000,007, we're already $400 over what we have to spend this year. So if you're going to give everybody a 20% increase, you're going to have to cut somewhere.
Yep, that's right. That would have to be a lot smaller increase than 20% for everybody. But that's another way to approach it, is to say, well, let's just give a small increase based on what the allowable amounts were.
I tried it with 15%, and we still have a significant problem.
Or you at 10%. Would y'all like to take a short break? All right, well, we take a break for 10 minutes, be back at 7:20. But before we go, I think, did you want to leave your motion on the floor?
I'll leave it on the floor, because it's been seconded.
It's been seconded.
Yeah, I'll leave it on there. I'm not withdrawing it.
Remind you of the sunshine law. Not that I need to. Okay, we'll be back.
Then you got the match, you just gave it. No, we just got one more. Yeah, that's all we got. You got the next three for the list. And you guys got the.
quickly ask you to deliver returns on that. And then what's the other one? So what you really need is a spreadsheet that runs the numbers, see what the value is. But the other thing is the issue about, that I Well, I mean, for discussion purposes. Now, the issue that was posed, but if you run it through the hospitals and trade and then it show that you get money, just have a memo entry. You know, have a spreadsheet and you put a memo entry for, but still run all the numbers. Yeah. Well, however, but, so you still generate